think there might be questions. Or are you just getting alerts up in your top? It keeps coming down. Does anyone have symptoms? I saw 11. Sorry.
Oh, for Meckel's? Yes, current jelly stool is synonymous with intussusception also. So, yep, better know that. Meckel's, though, here's the thing, guys. A lot of these things overlap. So, is that going to be like the distinguishing feature? Most likely not. But a Meckel's is going to have, they're going to have the big thing with Meckel's is that you're going to have the, you're going to use the Meckel's scan to detect it. Okay. All right. So let's keep going here. Intussusception. So yes, intussusception, the real hallmark for intussusception is going to be that current jelly stool. So what's an intussusception? Telescoping. Why?
Isn't it an immune response?
A what?
Isn't it an immune response?
So what happens is it's usually following an upper respiratory infection. Okay. And what happens is on the bowel itself, you have some things called Peyer's patches. Okay. So here's your bowel, right? And there's these little patchworks of immune, almost like lymph nodes on the bowel. Okay. So after that infection, the Peyer's patches get swollen and enlarged like lymphadenopathy, right? Well, this bowel is always peristalsing, right? So it's always squeezing down. And then what happens is the bowel gets to squeezing close to one of these enlarged lymph nodes, and pretty soon it telescopes over the top of itself. Okay? And then that's a problem because as it's telescoping, it chokes off the blood supply to this portion of bowel. This portion of bowel then starts to die, and here's your rectum. This starts to die, causes this tissue to slough, which is bloody and mucoid, and is going to produce current jelly stool. Okay? That's an intussusception. Now, here's the overlap. See that little part at the bottom here? Other sites also can cause intussusception. This is why Meckel's can be associated with current jelly stools. So that's the overlap. So Meckel's is a different situation, but Meckel's can predispose you to an intussusception, right? So instead of having these tiny little Peyer's patches that are inflamed, you have this big, huge Meckel's that can get swallowed up by the bowel also and cause you to have current jelly stools. All right, so what does it look like? Well, it would be very concerning if you saw that coming from a child, right? That current jelly stool. They're also going to have what they call this sausage mass on X-ray, and it's palpable. So when you hear that, it basically means the whole colon is big and huge, all right? The barium enema is your diagnostic test of choice for a bleeding intussusception caused by Meckel's or caused by intussusception, okay? So intussusception has multiple causes. One of them can be Meckel's. The other cause can be considered idiopathic, but normally follows a viral etiology because of the inflammation caused by the virus, okay? But the way to treat this is always going to be barium enema. The barium enema is going to dislodge that telescoping, and it's going to show us if it doesn't dislodge it. So it's both diagnostic and therapeutic. It may actually fix the intussusception. It may not, but it will also give us the picture to see that there's an intussusception there and to actually say, yes, this kid's going to surgery right now. All right, appendicitis. So appendicitis is going to be that classic triad. Does anybody know the triad for appendicitis? So it's McBurney is cholecystitis. So appendicitis is right lower quadrant pain, fever. Nope. Anorexia. So they have this history. This kid will not touch anything. He's got a fever and his right lower quadrant hurts. Okay. So that's why you always, what did I say about sick kids? Their PO intake is going to change. Okay. That's when you really got to go looking. If their PO intake changes, then you've got to go looking. The cause of them is almost exclusively from a fecal lift that goes down in that little tiny appendix right there, okay? Now, a lot of people say that the appendix doesn't do anything. I disagree. The appendix houses bacteria, and when we wipe out all our normal flora, it can migrate back and re-inhabit the bowel. But they won't find that out for 20 years. All right. So if it ruptures, they're really in trouble. They'll be peritoneal. What is a peritoneal sign? Diffuse pain, kind of a distended abdomen, board-like tenderness is a peritoneal sign. You know, you push on their abdomen, they're just like, they won't let you touch anything. Plus they're sick as stink, right? It's the appendicitis that presents atypically that fools people, right? Those are the tough ones. So my son Clay had appendicitis for 3 days. I let him suck it up. He had anorexia, he had a fever, and but I could have him jump on one leg. He was fine. He's just a tough kid. So we go to his parent-teacher conference because I'm like, you're fine. And I'm in school, and I'm watching him play, and he's running up the hill, you know, playing, and he's going like this as he runs up the hill. Because he's like stenting his own right lower quadrant and then rolling down the hill and then grabbing it again and running up the hill. I'm like, that kid is tough as nails. So we finished the parent-teacher conference. He's diaphoretic the whole time. And I finally tell my wife, I said, take the other kids home. I'm taking him in. And he is like the whole time, thanks, Dad. Thanks for taking me. I'm like, oh gosh, what a terrible person I am. So we took him to Toppenish. It was a really cool story, actually. So I did my surgical rotation in Toppenish. So they're like, do you want to scrub in? I was like, I do, but I won't. And so I got all geared up and I was like, but I do want to put him to sleep, you know? So I got surgical gowned up, rolled him back there. Of course, he's like 5, so he's scared, you know, and got to put the medicine to put him to sleep. And so the last person he saw was me, and that was pretty cool. So yeah, night. So, but that was cool because he wasn't scared and he didn't have to go back there with people he didn't know and stuff. So, but I didn't scrub it. I thought about it.
Yeah.
I know. It's a cool little hospital. It is. Okay. So most frequently these children are going to be around 10 or older, but most advanced in those less than 5 years old. So they kind of run the gamut of presentations here. Primarily, it's a clinical diagnosis. So this person is sick as stink. They're kind of in that kind of fetal position, if you will. They're going to have an elevated white blood cell count, and they're going to have an elevated CRP. Those are two tests that I really like to run on these people because it's not a long-standing inflammation. It's an acute inflammation. So that's what CRP is good for. What kind of a white cell count are they going to have? What's going to be elevated? White blood cells, but what type of white blood cells?
Left shift.
There could be a left shift, right? So number one, the neutrophils are definitely going to be elevated. And number two, they may probably have a left shift. And you guys are going to know what a left shift is before you even go into hematology. So what is a left shift? Everybody uses that term incorrectly. So nobody knows what a left shift is. What's a left shift? Immaturity. Good. Thank you. I think I've probably already hammered this home, but we're going to do it again. Lab techs like pictures, okay? So what we do is we see the development of a neutrophil from the start to the finish. So when a neutrophil is a little tiny baby, it has a nucleus like that. As the neutrophil starts to develop more and more, the nucleus kind of starts to coalesce. Finally, it becomes a band. And then lastly, it would be actually a segmented neutrophil with 6 or more segments. Okay? So when they talk about a left shift, it doesn't mean an overt neutrophilia, which most people incorrectly use that. If you say, oh, they've got neutrophils of 90%, that's a left shift. No. A left shift means that you shift toward immaturity, okay? So this is a blast, a meta, and a myelo, which you guys don't have to know this, a band, and a mature neutrophil, okay? So if you start seeing bands in the peripheral blood, that means you've shifted to the left of the development of a neutrophil. The reason why we do this is because the bone marrow sequesters neutrophils till they become adults. It doesn't kick the kids out of the house at 14. But if mommy and daddy lose their jobs and nobody else can make money, out go the bands, okay?
Is it the neutrophils that do this, or is it all of them?
The neutrophils traditionally are where you're going to see that. You're right, though. Sometimes you can see immaturity in other cell lines, particularly under some sort of infectious pathology. Like sometimes you'll see immature lymphocytes, but the lymphocyte doesn't develop like the neutrophil does. Lymphocytes really just kind of have this big nucleus, and you know, these techs can kind of differentiate them, but they're not as clear cut as this.
Is there ever a right shift?
The right shift is normal. So you would never use that term because this is all you ever see.
This is not.
So say that, so your normal neutrophil percentage, now we're jumping ahead here because you guys have this coming up. Your normal neutrophil percentage is about 60%. So you got 60%, 6 out of 10 of all the white blood cells are going to be neutrophils that fight bacteria, okay? In the presence of a bacterial infection, those can spike up to like 90%. And that's still not a left shift if they're all mature. When people really start to get crappy, right before they're going to die, they'll kick out all these bands and metas. If I start seeing somebody kicking out like 20% bands, they're going to die the next day. Anecdotally.
Is that where they get like bandemia?
Yep. Yep. That's it. That would be called bandemia here. And it's any more than like 5% bands is a bandemia. But if somebody has like a severe bandemia, then they usually croak. Like within
And that means
like 15%, 20%.
But the blood that they do have are only bands.
mostly like it's like a high amount of bands. And that's just what I've noticed being in the hospital, because I'd draw people's blood every day and then they'd spike this super high bandemia and the next day they'd be dead. But also, don't forget too, one thing that can be confusing is neutrophils also will spike with trauma or severe stress. So sometimes someone will come in after a car accident and you draw their blood just to kind of see their baselines, and they've got like 88% neutrophils. As long as they don't have any signs or symptoms of an infectious process, we do spill a lot of neutrophils with trauma and super stress. So.
Do you have to order like a micro then to actually see this? Because a CBC wouldn't tell you.
A CBC might, but usually if there's like 1 or 2% bands, each lab has a criteria that says, whoa, let's make a slide and make sure. So you can order a manual differential, or you can just kind of find out what the lab criteria is. In general, most labs have a pretty good criteria of saying, that seems weird. Let's go to the microscope and make sure that it's real. Okay. So here's our appendicitis. There's our triad. There's some signs that you can do, right? You can do an obturator sign, the psoas sign. Oh, I think I talked about it right here. Here we go. So there's this point. Oh, you said McBurney.
Yeah, weird.
Yeah. Oh my goodness. Good job. Cody, you're on it. It's the Murphy sign. That's the cholecystitis. So yes, McBurney's point tenderness. I always just call it right lower quadrant pain because I don't ever care about these all that much anymore, but you guys got to know them because they're on the boards. The Rosvig sign is something that you need to know, and that's just when you push on the left lower quadrant and it causes pain in the right lower quadrant. McBurney's point tenderness, the psoas sign. So a psoas sign is where you have the patient, which this is wrong because an appendicitis patient is never going to lay with their legs straight. But what you do is basically have them lift their leg and you put pressure against it, and it triggers the iliopsoas to fire, causing that to press on the appendix, causing pain in the appendix. Obturator sign is just where you put them in 90 degrees of knee flexion and you internally, externally rotate. So they like those signs because they're really testable. So make sure that you understand those signs. An Alvarado score. So what's an Alvarado score? Well, it's a good score to discharge people with right lower quadrant pain. This is not on the test, so don't get all Twitter-pated. It's just something that I want you to know for clinical practice, because next year, all of a sudden, half of this stuff isn't going to mean anything, and the stuff that really means something, you don't get a taste of. So the Alvarado score is really cool if you want to discharge someone with possible appendicitis. You go to your attending and you're like, well, he's got an Alvarado score of 3, so blah, blah, blah. I think I'm going to discharge him. And your attending will go, what the heck's an Alvarado score? And you can say, doc, it's on up to date. All right. So that's kind of a cool score to use. It's good for your documentation when you get into the real world or you go into emergency medicine, you want to discharge someone, you can say in your chart, patient has an Alvarado score of 3, so I'm not concerned for appendicitis at this time, but if their clinical presentation changes, I will have them return to the emergency department for further workup, right? So that's something that you want to, these scores are clinical decision-making tools so that later when you actually start to make decisions, okay? This is the thing about medicine. If you watch me do medicine, it looks really easy, okay? You just sit there, you're shadowing. It's like, I can do this. I knew that. I knew that. It's like when you're actually in the driver's seat and you're deciding whether to do the test or not, or to send them home or not, and your license is on the line, it becomes a much bigger decision-making game. And you want to use some of these scores to help you sleep at night. Okay, I sleep like a baby. And I see a lot of difficult patients. But if you know your stuff and you know some of these tools that you can use, you'll feel a lot better about the way you're treating people, and you'll have data to back it up. Okay, cool. I'm back here. We did Alvarado score. Are they seeing this? Am I back behind them? Okay, Alvarado score. There we go. Okay, so what's the appendicitis treatment? Well, you want to ask, what was the last time that they ate or drank? Why? Because they're going to surgery, okay? You're going to give them IV. You want to ask, always ask the surgeon what antibiotics they want you to start. They're probably going to say Zosyn, okay? But you need to ask first, because that's one way to really tick off a surgeon, is to just start whatever you want. Because you think, because the last surgeon wanted that, just talk to them. What do you want me to start? You know, haven't started anything yet, but I'm going to start something. Zosyn, yeah, which is analogous with Augmentin, but the IV form. A lot of times they'll do Zosyn if the patient is suspicious for like a MRSA or something. But in this case, usually Zosyn covers intra-abdominal bugs. All right, moving on. Biliary atresia. So biliary atresia is just a fancy word for a little tiny, tiny biliary duct system. Okay, so you got this biliary tree that comes down out of the liver where you've got your gallbladder, and then it dumps into the bowel, and it also goes up to the pancreas. So you should know that inside, outside, and sideways. You should be able to draw that from memory for sure, okay? Because there's a lot of pathology that occurs in that biliary tree. So you can have a common bile duct obstruction, you can have a cholecystitis, you can have a choledocholitis, right? There's a lot of things. It's like, is it in the duct? Is it in the gallbladder itself? Is it in the common bile duct? Is it in the pancreatic duct? Okay. All those things really matter. Okay. So normally bile flow is going to be present at birth, and then it will decrease with inflammation. Okay, so these kids are born and they're moving their bile fine, they're not jaundiced. And then a few days later, all of a sudden they start elevating their bilirubin levels. They become more yellow appearing, right? They've got jaundice signs, darkened urine, and then their stool might be pale. Why would their stool be pale? The bilirubin's not making its way into the stool, okay? It's in their body. It's spilling into the intra-abdominal cavity. So their stool's going to be white because the bilirubin and biliverdin is what makes your stool dark, okay? We break down red blood cells, right? We send that material to the liver, and then the liver stores it, sends it down the biliary tree where it stores it as bile and all this other junk. And all this stuff goes down into the bowel and colors the stool, right? Because it's a waste product. We don't need it anymore. We're going to get rid of it. If we're not getting rid of it, but we're retaining it, we're going to see problems with the stool. Gastroesophageal reflux, okay? You're going to see this a lot in little kids. It can be related to acid type stuff. There can be peptic ulcer disease. There can be other esophagitises like eosinophilic esophagitis. You can have esophageal foreign bodies, and there can be other gastritises caused by like an H. pylori infection.
Can you talk about EOE real quick?
Yeah.
So is that, I mean, they do talk about that that's usually reserved for kids, not reserved, but it's kind of almost leaning towards pediatric patients. Does that, I mean, how can you hang your hat on that as just being a total pediatric
What?
disorder?
Esophageal, esophageal.
Eosinophilic esophagitis.
No, because it's seen in adults also. So I don't know what the percentages are, but I know I've seen it more in adults. And maybe it's just because we think about it more. Or maybe they're born with it. And then now these people are really good at telling their history. Like, oh, I have this eosinophilic esophagitis. That's diagnosed with a biopsy, or they take some of the mucus there and they do a gram stain on it. What's the deal with H. pylori? Right. So H. pylori is a what? Bacteria. It's a bacteria that loves a super acidic environment. Okay. The guy that found H. pylori, nobody believed him. He was basically laughed at and they thought he was an idiot. And so he actually isolated H. pylori and ingested it himself and gave himself peptic ulcer disease. And that's how they were able to find out that it actually,
Different level of dedication.
that is some serious dedication.
I think you have some questions again. Sorry, I don't mean to be annoying, but
Where are they?
Up at the top.
Can you just read them to me?
Well, you have to open.
you gotta open the app. I had a question at home. I don't know.
Let's see. Let me move this.
Oh, okay. They're answering each other's questions.
Oh, okay.
Fair enough.
Okay. Cool.
Yeah. All right, I'll stop bugging you.
Okay, so gastroesophageal reflux, we talked about all that. So they're going to have this non-forceful movement of gastric contents up through to the esophagus, basically that the esophageal sphincter is not as tight as it needs to be. And so as the stomach contracts, you're going to reflux acidic stuff up into the esophagus. These kids might do this quite a bit when they're younger. And so especially like when we're breastfeeding or bottle feeding these kids, if growth is affected, we need to refer these kids to like a pediatric GI to check on them.
This isn't something that's still under something that needs urgent medical care, right?
No, this is
When did we
less
transition
urgent.
away from that?
Right after we got done with appendicitis.
Okay.
All right, so moving on. All right, so how can you help these parents? Well, you want to make sure that they're doing proper burping of their babies, right? Slower feedings, maybe less volume. Definitely avoid overfeeding. Definitely make sure that they're upright in their car seat. That's going to be pretty much standard right now. You can thicken the bottle a little bit with some rice cereal. But a lot of this like helpful stuff you guys will be doing next year. And so that will help you to kind of get better at it. But these are some tips because it seems like really easy right now, but when you've got a patient sitting there asking you for help, it's like, oh, I don't remember. So then we also want to rule out if there's any intolerance or if it's just solely mechanical. A lot of parents will be like, oh, my child needs soy milk, you know? So that's just, you're going to have to see where you fall and where your attending fall on that. You can try it. A lot of times what I'll do is have parents go get like one little box or bottle or whatever the heck it is, can of it, try it. And then if it works, then we'll fill out the WIC paperwork because it's like a 3-page packet. So they can get coverage on it, which is no problem. It's just, if it's not going to work, then so it's good to have them like try just a little bit, see if it makes a difference. So here's just the definition of GERD, right? There is increased risk with GERD if the child has a neurologic impairment, because they may not have the same function of their sphincters, and so they could have a tension, they could have a increased chance of aspirating. Okay, and then that's not good. Okay, also with like obesity, lung disease, this is not going to be really like your tiny pediatric patients. If there's coexisting esophageal atresia, and if they're a premature child. Okay, premature. Why would we care about premature children? They're not all the way developed. Their lungs also are not all the way developed. So if they were to aspirate, that would be probably more of a problem. Yeah. All right. So when is GERD a disease? When does GERD become GERD? Okay. So this is the Sanford syndrome. Okay. If there's acid-related disease, irritability, esophagitis, or hematemesis, that is all indicative of disease. If they're having poor weight gain, if there's respiratory complications such as aspiration, cough, stridor, wheezing, or apnea. If their growth charts are going the wrong way, then we really want to approach this like a disease state, and then it does become more emergent, right? Or at least urgent. Sanford syndrome is where they actually have secondary problems due to the GERD, okay? And you can look it up because there are some criteria that actually they put there. It's not super high yield, but it might be nice to just take a peek at.
So a few slides ago, you talked about how GERD is a complication of CF. Is that because the pancreas is compromised? And the pancreas is like one of their chief roles is to release bicarb to neutralize the acid.
I'm guessing maybe. I honestly don't know. I've never really looked at the link to that, but that would make a lot of sense, right? And I don't know if they're just what I'm trying to get at here is that with cystic fibrosis, if they aspirate, that's, so if they, and maybe it is a common link with cystic fibrosis, but you could definitely like reason that out. That would make sense. In this case, it's basically if a CF patient has GERD, you want to really aggressively treat it because if they aspirate, they're in big trouble. Yeah. Okay, so beyond infancy, 7% of school-aged children and 8% of adolescents may have some sort of presentation like this. Signs and symptoms are retrosternal and epigastric pain plus or minus vomiting. They're going to have that good history of eating hot Cheetos, and there may be some hematemesis. All right, but sometimes we got to think about this, right? If this kid comes in with this persistent cough, we might want to just try treating for GERD. They're going to probably think you're nuts, but if you're like, hey, if you can educate them a little bit and be like, hey, I've seen this before, because I have seen these persistent coughs that turn out to go to pulmonology, and 6 months later you find out it was GERD, which is really crazy.
Can that be the same for adults too, or kids?
Adults. I've actually seen it in an adult patient. She could barely breathe and she was coughing so much. And she went to pulmonology, she went to ENT, she did everything. Finally, they treated her for GERD like as just a, well, let's try it. And it fixed her. So she had like seriously $40,000, $50,000 worth of workup to tell her that she had GERD. All right, so how do you really diagnose it? In the real world, we usually kind of try to treat, and then the treatment is kind of diagnostic in its own way. Like That's what you can tell them too. This actually gives us information, even if you don't buy what I'm saying, even if you think I'm totally wrong, let's rule this out. Because if not, every other person that you go see is going to think in the back of their head that you have GERD and it hasn't been treated. So let's try the treatment and see what happens. But the gold standard of treatment is the barium upper GI, okay? So that's going to show us basically how that sphincter is working. You can do 24-hour esophageal pH monitoring, which is going to be, in this case, your gold standard. So sorry, I said the upper GI, but it's the esophageal pH monitoring. Let's see, where'd we go? Almost there. There we go. So 24-hour esophageal pH monitoring. I don't know a lot of kids that could tolerate that. But I suppose if it was bad enough, then you would want to make sure. If they had like weight loss and stuff, then you'd probably admit them to a pediatric unit with at Children's, and then they'd do this testing. And then the barium upper GI is also something you can do. There is just this physiologic reflux that is present in infancy that's kind of normal. So we want to try all the simple stuff before we overreact and do the real crazy stuff. And some of this simple management is increasing the caloric density. So you can add like a rice cereal or something like that. So it's a thicker, less thin feeding. You can try the positioning, make sure that they're burping. This casein hydrosylate is a formula that they can try. You can do a 2-week trial of that. And then in children and adolescents, it gets a little bit different. We want to limit the high fat content of food. We want to watch caffeine, spicy foods, chocolates, avoid tobacco and alcohol. So those are really your triggers for GERD. You know, all those kids love the caffeinated drinks and the hot Cheetos, and they will come in with that for sure. When I was in the lab, I had a doctor come in with a stool sample from a kid, and it looked like bloody stool. And he was like, can you just look at this? Just, you know, I know it won't be official, but just look at it because I'm worried about this kid and la la. So I fine, whatever. I work nights by myself, so I just did whatever. And so I make a gram stain. I'm like, yeah, it'll probably be better for the kid anyway to find out what's going on. And the gram stain is just all this fibrous stuff. There's like nothing in there. It's not even stool. It's not bacteria. It's just all these fibers like wrapped around each other. And I'm talking to the doc, and I'm like, I don't even know what I'm seeing. It just looks like a mesh of fibers. And he's like, oh, crap, let me talk to her. So turns out it was hot Cheetos. So she'd been eating hot Cheetos for like 3 days. And it was hot Cheetos. So it happens.
That's all her stool was. Just straight hot Cheetos. Cool.
I know. Good parenting.
What she's saying is I shouldn't eat hot Cheetos.
Not 3 days straight.
Okay.
All right. So there's some treatment that we can do with pharmaceuticals, right? We can use antacids after meals, aluminum containing antacids. We want to be a little bit careful with, okay? We don't want to overdo. As long as they're taking the recommended daily dosage, that's okay. There's the histamine 2 blockers, like